Yes, I'm provided with X-ray lateral X-ray lateral view of the knee joint. So I can appreciate degenerative changes in the form of osteophyte formations and reduced joint space, along with calcifications appreciated in the within the joint space and along the suprapatellar tendon.
Suprapatellar tendon, which is your quadriceps tendon, isn't it?
Yes. Suprapatellar region along the quadriceps tendon.
So the best term we use is suprapatellar pouch, right? Or suprapatellar recess. This is your suprapatellar recess, which communicates with the joint, yeah?
Yes.
So what are we seeing? What are we seeing there? Just repeat it for us.
I can appreciate the degenerative changes in the form of osteophyte formation, reduced joint space, and calcifications in the suprapatellar recess.
Right. Okay. So what kind of calcification is it?
These are kind of dysmorphic calcifications.
Are they of uniform kind of shape?
These are in a linear pattern, arranged in a linear pattern, kind of along the tendon.
Along the tendon, right? Okay. Well, I mean, we said they're in the suprapatellar pouch, right? Okay. We can look at the AP and see whether. Let me put the AP. Right. So I mean, the degenerative changes, you're right there. I mean, this patient has got degenerative changes, isn't it?
Yes, it reduced medial joint space is also appreciated.
So what is this? What's this pattern of? Commonly seen?
Osteoarthritis.
Exactly. So this patient got osteoarthritis, right? Okay. And then he has got all these calcifications within the suprapatellar pouch in the joint cavity, let's say. Okay.
Yes.
This?
So on the basis of these findings, my differential includes first of all the osteoarthritis, and considering these calcification or loose bodies, I will put CPPD in my differentials.
Well, CPPD, pseudo gout or calcium pyrophosphate deposition. Where do you normally see it typically?
In the knee.
Which structure kind of gets CPPD deposition? Well, CPPD leads to chondrocalcinosis, isn't it?
Yes.
You've heard about chondrocalcinosis, isn't it?
Yes.
So where do you see chondrocalcinosis in the knee?
Around the knee joint?
Around the knee joint or in the knee joint?
In the knee joint.
I mean, it's usually meniscal calcification, isn't it? The fibrocartilage of the menisci, you see kind of linear calcifications, or sometimes it conforms to the triangular shape of the menisci, isn't it? So do you see any chondrocalcinosis?
No, sorry, I cannot see it.
I mean, you might be right, but I think it's not a typical appearance. If you are trying to make a diagnosis of pseudogout, then you need to kind of see chondrocalcinosis. Yeah. Okay. So in the context of moderate osteoarthritis, you're seeing these multiple bodies. So what's the diagnosis? We have seen one case at the very start that was primary. This is
synovial chondromatosis. That was, and
synovial chondromatosis or synovial osteochondromatosis?
Osteochondromatosis.
Okay. All right. Okay. Let's go to the MR then. Right. What do you see there, Dr. Rida?
Yes, I can appreciate the multiple hypointense areas in the suprapatellar bursa, and along with the degenerative joint changes in the form of cyst formations, subchondral cyst formations, and
cysts. Where are the cysts?
I think
I haven't shown you any other plane. I've just shown you an axial plane. You think that's a cyst?
This one, no, but this is a lobulated kind of lesion.
Okay, we'll come to that lesion in a second. Let's just go back to these bodies. I think they're beautifully seen on the coronal, right? So you see they are kind of similar but a bit variable kind of size, isn't it? Lobula, okay.
Yes.
Right. And the other thing you notice with them is there a cortex to it? Difficult, isn't it? Because if you go back to the X-ray, it was more like a faint kind of calcification. Okay.
Yes.
So you see, if you go here, if I magnify it for you, it looks a bit cauliflower-like, but there's not definite cortex like the one I've shown you before, like this one. That's the fibella, right? So for osteochondromatosis, usually the bodies will be kind of have got a cortical rim, right? These ones are a bit fuzzy, aren't they? They're not as corticated. They don't look corticated. Okay.
Yes.
So what we are seeing probably are just chondral bodies on MR. These are just kind of cartilage bodies, right? Like you said, synovial chondromatosis. So this is probably just chondromatosis, secondary to degenerative change. But let's see where the degenerative change is. Let's see where the degenerative change is. I want you to look at this sagittal. So that's the medial side. This is the lateral side. So the lateral side is okay. You see, that's the cartilage, that gray. This is on PD fat separate. You see it very nicely. The cartilage, right? Okay. And the tibial cartilage, the lateral meniscus is fine. That's your patellar cartilage. All right. Then we move on to the medial side. Where is the cartilage here? You can see the cartilage at the back. But what about the center? What about the center?
It is eroded.
Eroded? Better word. There's no cartilage there, isn't it?
Yes.
So how do we say that in our report?
There's a discontinuation.
Complete chondrosis. Yeah?
Yes.
Okay, there's no cartilage, but if you see here, the bone is okay there. The bone you can still see, right? So if it had the bony fragment, you would have called it osteochondral defect, right? But this is just a chondral defect. There's a large area of chondral loss in the bony compartment. And probably from here, all these cartilage have peeled off and formed these cartilage bodies that are roaming around. Yeah?
Okay. So it is secondary chondrocalcinosis, synovial chondro.
I would say this is secondary. Yeah, you can say secondary chondromatosis, or just say these are just kind of chondral bodies, basically. Yeah. It's just, it doesn't matter. It doesn't matter. It's just an OA with multiple chondral bodies in the suprapatellar recess. All right. What about this one? That lesion there that we are seeing in the tibia. Any thoughts about that?
Bodies. It is intramedullary.
Yeah, it is in the bone. Yeah. Okay. But yes, what's the shape of it?
It is intramedullary lesion, and it is kind of lobulated appearance. And it is near the it is subarticular location.
It's quite away from the subarticular space. I mean, subarticular means it should be somewhere here.
And near the physis.
The margin is bright on this PD or T2 weighted image. This is a chemical shift artifact, which is very typical for an enchondroma. This is a cartilaginous lesion, and it's a benign lesion. That's why we call it enchondroma. And it's got this kind of a chemical shift artifact. So whenever you see a lesion in the bone with this kind of a lobular appearance, I mean, we didn't see it on X-ray because it's too small, right? Okay.
Yes.
This is a benign lesion. You don't need to worry about it. This is just anything which is less than 5 centimeter without any edema around it, without any, if it was next to the cortex, if there was any reactive cortical chin, then you get worried about. But this is a silent enchondroma, just a cartilage rest, you can say, right? They're just by the by. It doesn't have. It hasn't got any relationship with these cartilage bodies that you're seeing here. They're two different.
Okay, it is incidental finding only.
Yeah, incidental. Okay, and there's a small ganglion cyst arising from this proximal tibial fibular joint, which is again incidental. Yeah. Okay.
Okay.
All right. Any questions?
Yes.
No problem. Okay, I think we should go for this one. Right, who is next, please?
Dr. Sana is next. Dr. Sana,
Okay.
kindly unmute yourself.
Assalamu alaikum, sir.
Walaikum salam ji. Right, okay. So I'm going to show you this case from ER. This is a 31-year-old lady who had a fall. Okay, and just to change the scene, I'm going to show you the CT, right? So non-contrast CT head.
Sir, these are axial CT images, brain. I can appreciate that this is a plain study, and I can appreciate that there is diffused soft tissue thickening around the scalp with air, suggestive of any traumatic injury. And also I can appreciate that there is hyperdense vessel appreciated in the left cerebral hemisphere in the territory of the MCA.
That's fine. Ignore that. Don't worry about that. It's okay. All right. Okay.
Yes, that's normal.
Let me show you the coronal reformat, right? Okay, let me just scroll it for you and then you can decide. That's better.
The few hyperdense foci I can appreciate.
Where?
Sir, in at the gray white matter junction at the.
Okay, right. I mean, okay, you take my word. There was no intracranial abnormality. It was just a large scalp hematoma, right? Okay, but this patient had neck pain, so we did an X-ray. All right.
Right.
So I want you to describe what you see on this neck X-ray for me.
So this is X-ray, lateral projection of cervical spine. There is straightening of the cervical spine, loss of the normal curvature, and there is enterolithiasis of C1 over C2. And
sorry, say it again.
Anterior displacement of the C1 over C2.
So where is C1 on this? This is your C1. This is your C1R.
Yeah. I think it's slightly forward as compared to the C2.
Well, the pre-intense space is okay. You mean this one? This is what you're pointing to. That this is your kind of lateral mass of C1, which has gone anterior. Yeah.
Yes, sir. And also.
That's fine. Ignore that. Okay. There's other abnormality. Keep looking, please. In the subaxial spine.
Right. I'm looking at the bones. I can't see any cortical break. The lines, the cervical lines are fairly parallel, and a slight increased soft tissue thickening is seen, sir, in the precervical region.
So you think the alignment is normal, or there is something which is not right here? Does it look like a normal lateral cervical spine X-ray to you?
So there is a straightening of the cervical spine.
Excellent. So great. Okay. That's the first thing we report, isn't it? There is straightening. There's loss of normal cervical lordosis. Yeah.
Yeah.
All right. Okay. good. And if I just remind you, we've just seen her CT head. So on CT head, there wasn't anything inside there was nothing intracranial, but where was the hematoma?
So it was scalp hematoma.
No, it was scalp hematoma, but where about in the scalp it was?
It was on the parietal region, top.
It was at the higher convexity. It was straddling, right? Okay.
Yeah, vertex.
Yes, exactly. So how would this patient have fallen?
So like a head-on injury, like during diving or something?
Yeah, okay. Diving is a possibility. No, it wasn't diving. She fell off downstairs. But
yeah, like the first impact was on the brain, and obviously, considering that, I'm considering injury of C1 or C2. But
good. So that's more like axial loading, right? Just looking at that,
yeah.
You think that she's been hit on the head, right at the vertex. So axial loading, right? Okay.
Yeah.
So okay, C1 is okay. You want to look at the C1? I can show you this. All right, that's the C1 there for you.
So I think there is some lucency at the base of the dens, which is transversing to it, and I think it is a non-dislocated dens fracture type 3.
Okay. Well, do you get that with somebody who kind of falls on their head? Usually you get dens fracture when somebody falls on their face. Right? Okay, but this lady has fallen on her head. So you're thinking about C1 fractures, right? But C1 alignment, if you look at there, the lateral masses, they are well aligned. There is no splaying.
There is no lateral displacement.
Yeah. And again, there's no widening here. They're kind of equidistant, more or less. Okay. Let me get. Let me just. I just want to kind of get you thinking. So let me go back to this. Do you see any abnormality somewhere here in these levels? If not, we'll move on. Don't worry about that. Do you see anything which is not right? Let's say 2, 3 are
2, 3.
C2, C3, C1, 2, 3 are okay. What's happening below them? Okay, fair enough. That's fine. I'm sorry, sir. So depending on that, this is not a normal X-ray. We all agree. There is cervicalordosis. There is loss of cervicalordosis. She has got a vertical kind of injury on the CT head. So we should do, if you are faced with this problem, always say, get a CT neck done, right? Okay, yes. So let's get the CT neck for you. All right, it's a bit neck and upper thorax. That's just a bit of sometimes generosity in radiology is not very helpful for reporting radiologists, but that's how it is. Yeah, all right, okay. But we are more, okay, I'm scrolling.
Okay, right, sir, I got it. There's a cortical break.
Wait, great, okay, just hold on there. I'm gonna scroll for all of you, and then we're gonna talk about that, which fractures do we see. So this is the sagittal, parasagittal images, all right. Okay, so if I stop there for you, Dr. Sana, which fractures do we see?
There is a cortical break at the inferior part of the C5 vertebra.
All right, there, okay.
Yeah. And it is incomplete and not completely separated from the parent body. And
there was another thing, isn't it?
Yes.
So where is the fracture? This is your C1. This is your C1. This is your C2. So where is the fracture?
Then the spinous process. Right here.
It's not a spinous process. It's the articular pillar of your C4.
Yes, sir. Superior articular facet.
Sorry, C3, beg your pardon. This is your C3. Yeah. All of you can see that? You can just do this, yeah. So you see that? There, yeah?
Yeah.
There is this is the impact. So there is this intra-articular fracture involving the articular pillar, okay, going into the facet joint, right? Okay, on one side with a bit of widening, but no kind of dislocation. Then you go to the other side on the same level at C3. The other articular pillar is intact. So it's a unilateral articular pillar fracture. But that's fine. That's one fracture. But what about this fracture and probably a fracture here? So these are two kind of anterior-inferior. There we go. I think that's better seen there. Yeah. So Eddie, do you know what's the name for these fractures?
Anterior-inferior usually are extension fractures or flexion fracture, and
well, it will be either extension or flexion. So that's
yes. Considering it that there is no cast around the patient, so I think that's a stable injury and it's extension teardrop and no disruption of the cervical lines is seen.
I think it's called flexion teardrop, right?
So usually in flexion we have disruption of various lines, but I'm not sure about here.
But teardrop fractures, they are technically unstable injuries, right?
Yes, sir. Flexion teardrop is unstable.
Usually the anterior longitudinal ligament and the posterior longitudinal ligament goes, so they are unstable injuries. Yeah. Okay. And now with that view, 2, 3, 4, 5. Now let's go back to the X-ray, just to learn from it. Go back to the X-ray, and then that's 2, 3, 4, 5. All we see here is just a little bit of something, but I think it was difficult. I think it will be very difficult to call that. But it just, you have got a gut feeling that this spine is not normal. Let's do the right test, and then you find the injuries. Yeah?
Yes.
A young lady who is 31-year-old, and she has got lower back pain.
Right. So I've been presented with an X-ray pelvis AP projection of a young female patient presenting with back pain. There is a well-defined large lucent lesion centered around the right posterior ileum with a narrow zone of transition with the parent bone. The margins are non-sclerotic, and I can appreciate a cortical breach along the superior aspect of the iliac bone. This lesion appears to be subarticular in location and does not appear to be involving the right sacral ileum. So on this projection, I cannot appreciate a very well-defined soft tissue component to the lesion. There is no matrix mineralization noted. I am looking for any periosteal reaction. I cannot appreciate any. There are no internal septations, bony septations noted within the lesion. This is a solitary lesion. I cannot appreciate any the lytic or sclerotic lesion within the rest of the bones. There are no joint erosions or symphysis pubis erosion, and the bone density appears normal as well. Right. So this is a solitary lucent lesion. And considering the age of the patient, I am considering, and the subarticular location of the lesion, I am considering giant cell tumor as one of my differential.
Good.
This is not a very expansile or an aneurysmal lesion. The other differential would have been an aneurysmal bone cyst.
Right.
For this appearance.
Why do you say this is not expansile? What do you mean by expansile lesion? I mean, there is a large lesion which has replaced the bone, and you can't see the top cortex there. So this is as expansile as it gets. No.
Right, sir. But there are no internal septations to it, sir. But I am considering GCT as my first diagnosis and ABC in my differentials. The next investigation should be an MRI examination.
Apart from these two, could it be anything else?
So the other thing I was considering was brown tumors of hyperparathyroidism, but there are no signs of hyperparathyroidism in this X-rays.
Which?
And
so that's metabolic, right? Okay.
Right, sir. Sir, infection doesn't look like an infection to me, sir. The flat planes look nice, clear.
So when you talk about bone lesions, you've got a large expansile subarticular lesion. You talked about primary tumor, which is GCT or ABC. What other bone you are aware of?
Then we can think of expansile mets, like mets from an RCC, but she's a young patient. She's in her 30s. That would come down the list.
Yeah, exactly. But yeah, you can't exclude that, isn't it? Just on the basis of this. Yeah.
Yeah, yes, sir, definitely.
Whenever you say primary bone tumors like GCT or ABC, secondary bone tumors is unlikely, but I mean, is a possibility nevertheless. And you said RCC or
thyroid, sir. So it can be met from a thyroid.
Yeah, breast can give you. Breast or lung can give you. Yeah, okay.
Yeah. Right, sir. Right, sir.
Fair enough. All right. Okay. So, what's the next step then? How can you confirm what it is?
So the next investigation should be an MRI examination. There is a well-defined T2 hyperintense cystic lesion involving the right posterior eyelid blade.
Are you sure this is cystic?
So this is T2 hyperintense. This looks like fluid.
Okay, so how would a cellular tumor look like? A cellular tumor can be T2 hyperintense as well. Okay, let's go.
This intensity matches to that of a fluid.
I agree. But I mean, look at the fluid here. Okay, that's urine.
Right.
Okay, well, that's one thing. I think you're right. I mean, first thing comes to mind is that it's a large cystic kind of lesion. If it was GCT, what would it be like on T2?
So a hypercellular GCT would be T2 hypointense.
T2?
A hypointense. It would be dark on T2.
Why it would be hypointense?
So because it is a hypercellular tumor, it usually appears hypointense on T1 as well as T2.
Not all hypercellular tumors appear hypointense on T2.
Apart from that, so it can have hemorrhagic components and a lot of fibrosis in it.
That is the main reason. That has got hemosiderin, so it will appear kind of hypointense on T2. Yeah. Okay. Anyways, that's by the by. But then, okay, on that image, do you see any kind of pathognomonic feature?
Yes, I can see a fluid level in one of the cystic components. I do see a level in that.
So you see, and then it's got these kind of septations.
And then again, I can see the septations as well. So this is a multiloculated. There is avid contrast enhancement of these septations and the margins of the lesion. There is no enhancing solid components within the lesion itself.
Just don't use the term avid, right? Avid. When you say avid, it means the whole thing is enhancing. Though you said the walls. Fair enough. Just say marginal enhancement. That's it. Or the margins are enhancing. So it looks like an ABC, isn't it? That's your kind of more plausible diagnosis in this case, isn't it?
Right, sir. Yes, sir.
So what types of ABC do you know?
Sir, ABCs can either be primary or they can be secondary to any underlying lesion, like GCT, or they can arise from, they can be usually post-traumatic, or from like in lesions like dysplasia or GCT. And then another lesion that is very similar to an ABC is a telangiectatic osteosarcoma, but that would be more that would be having more of a solid component and soft tissue component to it with an aggressive reaction, periosteal reaction.
Well, she's 31. I mean, who knows? I mean, she might have it when she was 20. Yeah. But I mean, I think in that age group, GCT and ABC, it's the location. It's the location that's the key. This is a typical, if you look at the large series of ABC, posterior ileum is a common location of these expansile cystic lesions. Yeah. Okay. But obviously, GCT, ABC, you have to put in the differential in anybody who is in this age group 30. ABC is not, I mean, obviously, I mean, like bone cyst, simple bone cyst or ABCs, usually you see them in somebody who's 15 or who is kind of skeletally immature. But people live with this. I mean, it's not causing them any problem by the time they present. It might have been there for 10 years. Who knows? We don't have any imaging before, right? So sometimes, I mean, these age limits are not kind of written in stone. So you have to just kind of give it a bit of flexibility. Yeah. Okay.
Okay. So I've been provided with the frontal projection of a knee joint, both knee joints. Here I can appreciate that there are few so bilateral knee joint pain.
No, unilateral.
Okay. Here I can appreciate there are few sclerotic region noted within the proximal tibia of the left knee, and
that's fine. Ignore that. Just talk about the joint and anything else. Talk about the joint spaces and anything else.
Okay.
Please. Yeah.
Okay. So in the joints, I can see that the right joint is normally, however, slightly medial compartment narrowing, but left is in the left joint. I can appreciate that there is there the space is very narrowed, and there is tibial spiking noted with the.
Okay, let me guide you there, please. Yeah. Okay. So if you look at this kind of fat pad here, right? This kind of line, okay, in the right knee, that's there. What's happening
so
to that
it's lost
line
in that area, and there is soft tissue density area which is causing the uplifting of that fat pad, and it is extending upward. And it is also causing slight endosteal scalloping of the bone.
Okay, probably. I'm not convinced, but yeah, okay. But all of you should appreciate there is this kind of abnormal soft tissue hair.
Yes,
you're not really seeing hair. Yeah, it's a bit subtle,
yes,
but I think now when you start comparing, then you notice there is something here which is not hair. Yeah, okay.
Yes,
that in background, you would like to see a lateral of the left knee, isn't it? So this is the lateral X-ray of the left knee. What does that tell you?
Okay, sir. There is that hypodense, radiolucent, irregularly defined areas noted just anterior to the distal, just posterior to the distal femur, and with elevation of fat pad. And sir, and there is also
the question is it an effusion? Most likely, I mean, on X-ray, you just say this is probably an effusion, or it could be soft tissue.
So it could be traumatic hematoma.
I mean, there's no history of injury. So it's an atraumatic unilateral left knee swelling in a young guy. So if I give you that history, what's your differential? Unilateral atraumatic knee swelling.
Sir, it could be due to any underlying malignant process going on, or
joint-based process.
Yeah, sir, it could. Sir, can it be fluid? Sir, you are saying that fluid is not a possibility here.
No, I'm saying it could be. I mean, on the basis of X-ray, it's difficult, isn't it? All right, because obviously it's, X-ray, young patient with symptoms. So we did an MR, right? So this is an axial PD fat suppressed. There is some fluid there, right? Okay. So this is a T2 weighted image. Do you see any abnormality?
So there are multiple hypo-intense lobulated foci in a group form noted within the joint space, and these are appearing hypo-intense, and it could be PVNS.
What is PVNS?
Villonodular synovitis.
What's the new name for PVNS?
Sorry, sir, I don't know.
Okay, no worries. Yeah, I mean PBNS. I mean, okay, you and why do you say PBNS? Because
so it's appearing hypointense on this T2 image, and these are within the joint space.
No, these are arising from the synovium, right? All of you can see.
Yes, sir.
This is the synovium, right? These fronts are your synovium, right? So it's a synovial-based kind of a neoplastic, right? Which can be. It's now called tenosynovial giant cell tumor, all right?
Okay.
Tenosynovial giant cell tumor, whether it's of your tendon sheath, like what we used to call giant cell tumor of tendon sheath, or whether it's in the knee. I mean, it could be diffuse, like just all you see is just hypointense synovial proliferation, or like in this case, it could be lumpy and bumpy, like it's kind of a bit focal.
Yes, sir.
So this is a typical appearance of tenosynovial giant cell tumor affecting the knee, right? And it is hypointense, like somebody said GCT of the bone is hypointense because it's got hemosiderin. Look at that. This is gradient now. You see the gradient? All this is hemosiderin-laden synovial proliferation. Yes, this patient doesn't have hemophilia. This patient didn't have any trauma. He is not on any anticoagulation. So all these things excluded. And the other thing is that this is the lesion. Whenever you see an intra-articular nodular mass-like abnormality, particularly in the knee, I mean, you can see it around the ankle. I mean, it can happen any synovial joint per se. I mean, it's been described, it's been case, but the commonest, I would say, 70% of PBNS, it happens in the knee. Okay, painless, red swelling. This is PBNS.
Sir, what's the appearance on the X-ray? Is it radiopaque or radiolucent?
Well, it's soft tissue, right? It's not calcified. So on X-ray, all you see is just a bit of soft tissue abnormality, right? Particularly, I think, let me put, I mean, it's a bit subtle on X-ray. I think never diagnose PBNS on X-ray, right?
Yes, sir.
It just somebody has got a painless knee swelling, he warrants a knee MR or knee ultrasound. You can start with ultrasound if you can do that, and then to see there's a diffusion. This is a post contrast now. You see this is the kind of marginal enhancement of the synovium. This is all enhancing synovium, and look at that big sausage like nodular kind of mass-like lesion in the supralateral recess. This is tenosynovial giant cell tumor of the knee. Okay.
Yes, sir. Yes,
right.
sir.
Okay. Any ideas how is it treated?
So I think it's a synovectomy is done for it, and if the patient is symptomatic.
Yeah. Okay. I mean, traditionally it was synovectomy, but the problem with synovectomy is, I mean, how much synovium do you take out? It's a knee. I mean, you can't rip the knee of its capsule, isn't it? So nowadays they do. I mean, can you inject something in the knee joint which will kill all these cells?
Sir, sclerosis. No, sir, that's not. Sir, any agent that can. Sir, I don't know.
Have you heard about chemical synovectomy?
Sir, but not the name of the chemical agent.
It is. I think it's yttrium. Yttrium, which is the laser kind of thing, but there's a yttrium, I think, tracer that you can put. It radiates some radiation, and then it just kind of gets rid of it. So that's the new kind of established treatment. But again, this patient had it. It was okay, and then this is the last scan when you are still seeing some kind of recurrence of those lesions. So that was the elbow radiograph, right? Okay. And I want you to just, I mean, I could have shown it to someone, but you see this soft tissue swelling here? There is some widening of the radiocapitellar joint. There is some periosteal reaction probably there, but here as well. And you see these olives there, 1, 2, 3. I'll window it for you. These are the lymph nodes, all right? But let's look at the lateral. Again, you see, you're seeing these lymph nodes, you're seeing this kind of abnormal kind of soft tissue, some joint destruction there. And then I'm going to show you the MR. So this is a post-contrast MR. Now watch out. Okay, sorry, let's make it smaller. So you see, it's a bit different than I have shown you. I mean, it's got this kind of a lobular synovial enhancement, but there is focal enhancement in the capitellum. There's focal osteitis and all that infiltration into the bone. Usually synovium, tenosynovial giant cell tumor doesn't invade the bone like TB can. Infection doesn't respect bone, right? So look at this. Yeah, this is the plain T1 weighted image. Again, you're seeing abnormal signal osteomyelitis of the proximal radius of the capitellum, which is spelled into the joint. And if I show you this one, this is probably better. There. So that's, again, this is how TB will look like. I mean, this is like a textbook case, but obviously, I mean, you can have variable kind of forms. The other thing is, I mean, again, it is a synovial based kind of process. It started in the bone usually. And the other thing is, probably on this one, I can show you better, is there. So that's a Brody's abscess. We were saying Brody's abscess. So this is how Brody's abscess will look like, right? We had a focal kind of enhancing, eroded kind of lesion here on this T2 fat suppressed thing. And then you got this edema. This is, again, the other thing is sinuses. I mean, TB, as you know, it forms sinuses, right? So that's a collection in the subcutaneous fat, which communicates with the joint. And the last kind of image I'm going to show you is, we started. So this is, yeah. So this is the post-contrast image there. You got this collection, that's the sinus tract, and this is all kind of enhancing synovium with osteomyelitis. So that's how, it's an ugly looking kind of process, usually TB, when you catch it this way. And these are just the lymph nodes there in the epitrochlear group. So yeah, TB can look like, I mean, there are a few similarities here, but important differences, I would say. Yeah. All right.